Hello, everybody. Good morning or good evening from wherever you come from to join us for another session of Virtual Global Spine Conference. I'm really honored to host my close friend and partner, Dr. Kevin Swong, who is an assistant professor of neurological surgery at Northwestern University Feinberg School of Medicine. He's an expert in both spinal surgery as well as peripheral nerve surgery. He was kind enough to agree to spend some time with us on this platform and speak about some trauma cases that he has taken care of in the past couple of years. Certainly trauma, treating spinal trauma, whether it's craniocervical, cervical, thoracic, or lumbar, is very dear to my heart specifically, and I really enjoy the thought process, the biomechanics that is involved in the decision making. So without further ado, I again thank my friend Dr. Swong for spending some time with us this evening.
Thank you, Dr. Dali. That was a very kind introduction, and I will be sure to pay you your bribe next time I see you. I will apologize in advance. So I'm traveling, and my internet wasn't behaving, so I had some videos lined up, but they're not going to really show very well, but we'll talk through it, and it's going to be an acceptable presentation. Not great, but acceptable. So the first case, most of these cases are actually from my most recent call last week. This is a 77-year-old gentleman who happens to be an emergency physician at the Mainz institution, who was getting ready for work, tripped and fell, and took a funny kind of tumble, and then went to an outside hospital. And he was primarily complaining of neck pain and some upper extremity numbness, but some pain limited weakness, but no true weakness. And then he wanted to get transferred down to the mothership, as it were. The next slide would have demonstrated a unilaterally perched facet at C5-6. Which was quite impressive. And I think it, like most of these things, the reason I chose it is because everybody has their opinions about front or back, or front and back, or some kind of combination of a anterior posterior circumferential reduction. He, since he's an ER physician, he asked me, when I was in training, we just reduced these at the bedside and just let it alone. And what do you think about that? And I said, we don't really do that anymore. There's actually some data to suggest that if you were to do that, he would have a 25% chance of not staying fixed. So the resident really wanted me to do this from posterior, and was pretty confident we can do it from the front. I think the next slide just goes over some considerations for these kind of injuries. If it's a bilateral jump to perch facet, in general, those tend to be easier reduced than a unilateral lock facet, certainly, because there's more ligamentous injury.
Yeah. So, Kevin, great case. So, so does the, you can see here on this side, I don't know if that's the right or left side, you can see autofusion.
That's the right.
So the right side of C3 and C4, would that change your approach or strategy? In my view, if you have a unilateral locked or perched facet, I don't think about it too much. I'll put the patient in cranial traction, reduce it, and then go from the front to do a single level ACDF. I always obtain imaging. I get an MRI to assess the discal ligamentous complex, and I also get vascular imaging with any fracture. I mean, maybe that's an overkill, but certainly a stretch injury to the vert or like a dissection can't be ruled, can happen with these. So what are your thoughts about that?
Since it was unilateral, I prefer anterior approaches when it's possible. I think, the other controversial thing, or not controversial, but point of discussion is plus minus MRI, right? The protocol that I've heard that I kind of like the most is if they're incomplete and you think you have to go from the back, get an MRI, basically. Or if you think you're going to go from the front and you think that by going from the front, you're going to directly address the disc herniation. Sorry, if they're and then, you could probably just, some people don't get an MRI first in that situation, which I think is reasonable. Again, he was neurologically intact. I think getting an MRI certainly would have been very reasonable, but his CT didn't look that bad except for the one injured level, in terms of like disc herniations or spondylosis in general. And it wasn't locked. I think if it was locked, I would have been a little more concerned about it.
Okay. In the chat box, what's your most, to our audience, what's your most go-to procedure for these unilateral perch or locked facet? Is it anterior, posterior, or front, back? As I mentioned, the way I treat it is traction, realign, and then go at single level in the front. But certainly, going front or back, as long as you realize this is an unstable injury, the answer is correct, like as long as you stabilize it. So do you guys, Amna, do you get access to the chat box? I don't see it here. Let's see. Okay.
So this was just from that paper about, some guidelines about the amount of traction and the head position that you want to be in, and plus minus Caspar pins. For this one, we did elect to go anterior. For me personally, just because the residents and the trainees, in my mind, if there are two equal choices, sometimes I will make the decision based on what I think the residents will get the most educational value out of, assuming it's safe. And so for that reason, ironically, there had been another perch facet case from our colleague early that week, and they went posterior. And so that was part of the motivation to go anterior, was so that they can see that it was done. I will say the resident did not think that we could do it, and I thankfully proved her wrong. Him or her, I should say.
So that's your technique with Caspar pins, I suppose.
So for this one, we did use Caspar pins. I put them in Gardner-Wells tongs, and I put a cob in the disc space after it was removed to try to get it to reduce. It was only perched, so I didn't hear like a big click or see a big change, but the radiographs showed that he was able to reduce. I think it was just the next slide. Oh, this is if you go posterior, and I've done it this way too, and it's very simple also, but the position is kind of harder. Then you have to worry about the flip, and if it gets worse in their flip and monitoring and things like that. So that's another reason why I like anterior, because there's just less movement of the patient. I get worried if it's like a really unstable fracture, if it's going to get much worse when you flip. But because the ligaments are disrupted, once you expose it and you just drill a little bit of the bone out, you can just kind of pick up the facet and then just lock it back in and put in your lateral mass screws and fuse it.
Okay.
So this was going to be a really cute drawing, because on this x-ray you can actually really see very nicely the perched facet. So those are the two facet joints of 5 and 6 respectively on this lateral x-ray. It was just a very nice photo. This is obviously pre-op, and you can see the Gardner-Wells tongs that we had placed on his head.
Now you're distracted, obviously. You can see the disc space here, how it's robust. Now, yeah, this is great. So one thing one should think about all the time is, let's say you have a fracture dislocation and you want to reduce it intraoperatively with the cob and with the Caspar pins. Make sure that you're not reducing them into a pre-existing stenosis. That often happens with really older adults with severe spondylosis. Then they have a fracture dislocation. So if you're reducing them and you're abruptly back to the pre-existing stenosis, you can actually hit the cord with the osteophytes. So always think about that. That's why also pre-op imaging is important. It's a good look at the canal caliber, because sometimes they have pre-existing stenosis, they sublux, and then you're reducing them abruptly, especially with not with traction. I'm talking about the cob technique, where you twist the cob and you're trying to kind of distract and have the facets realign. You can abruptly reduce them into stenosis, and that can cause worsening spinal cord injury if they're incomplete.
Yeah, and this goes without saying, this was monitored, obviously. So all the maneuvers had motors pre and post maneuver. And then, if you're going to do this from the front, you want really long screws, right? Bicortical, ideally. He needed a big cage just because he was so distracted from his injury. This is him, obviously with the cage on, but even without traction before the plate and cage went on, his disc space was just very widened from his trauma.
Do you use fixed angle screws or variable angle screws in those situations, trauma situations?
I think most people do fixed. These are variable, and they are they're longer than I typically place, again, but I think most people would place fixed.
Yeah, as long as it's a strong bone, it doesn't matter really.
So that was the first case. That was Saturday. And then on Sunday, 77-year-old female came in with cranial nerve palsies, basically, that were getting worse and worsening neck pain. And when they were telling me about it, I'm like, why am I hearing about a cranial nerve patient? But if you go to the next slide, you'll kind of see why. And
what do you guys think in the chat box? Why would someone have dysphagia, like brainstem symptoms, in addition to neck pain and maybe weakness and numbness in the arms and legs? But let's say someone has cranial nerves, what would cause that the spine surgeon would be
oh, sorry, to go back. So there's a question about reducing facets awake in the ED or while under anesthesia. This one, he was reduced in the OR after anesthesia, but after monitoring was placed.
Okay, all right. So I would think that this may be either basal invagination, cranial settling, or something like that when you start thinking about like brainstem localizing signs. Okay.
Yeah, I shouldn't talk to the cranial vertebral junction expert. That was a gimme question, Otter.
Okay, great. Okay, let's see. We don't have any co-hosts to look at the images here, so let's describe it. Why don't you describe it here, Dr. Swong? Let's see.
Yeah, so these are mid-sagittal cuts. The first one's a T1 slide that shows a retroodontoid pannus with compression of the brainstem, and the CT largely demonstrates that pattern. With cranial settling or basilar invagination, I guess whichever way you want to phrase it. This is on the right, it's a CTA, just to look at the vertebral anatomy. Nothing was compromised, but just for surgical planning and things like that.
Yeah. So the way we differentiate between cranial settling, it's semantic, but it's important. So the way I think about it, cranial settling is a C1, C2 joint issue. So you see that in rheumatoid arthritis patients, destruction of the C1, C2 joint causing instability, and then cranial settling. Then the dents will impinge upon the brainstem and then be located in the posterior fossa. Basal invagination, the relationship between C1 and C2 is normal, and it's usually a skull-based softening issue or a congenital issue that is where you see the skull-based or invaginate into the C1 C2 complex. Okay, so the C1 C2 relationship is normal. You see that in OI, osteogenesis imperfecta. So that's how differentiated. This is, I would call this cranial settling with retroodontoid pannus too. But does the patient have, did she have or he had rheumatoid arthritis or no?
So no history. The RA factor was negative, and the inflammatory markers were mildly elevated as to be expected. So the jury's still out, but we did proceed with surgery.
So that's so destructive process to the dents too. So but can happen with CPPD to calcium pyrophosphate dihydrate depositions too. Okay, so what was your thought process about this? Okay, you have this patient with brainstem compression.
So I think, when you think about this, you could go like for a direct decompression, right? If you wanted to go straight for the lesion. That's not what I like to do, but I think that's part of the thought process at least. It's essentially, in my hands at least, impossible to directly decompress this from the back. So my thought process was to realign, so distract her head a little bit, fuse her in place, And then we'll image her serially to see how this lesion changes over time. But stabilization and distraction were the main goals of surgery.
Yeah, I agree. I mean, a pannus in the front will shrink once you stabilize the joint in the back, like with the C1, C2 fusion or an OC fusion, dealer's choice. I would go to the occiput here because really the dent is really destroyed.
Yeah,
You get multiple
I
points
agree.
of fixation, but certainly you don't have to go from the front to relieve the pressure off of the brainstem unless it's really severe, because these shrink with time when you stabilize the upper cervical spinal joints. Good.
Yeah, I think
So,
for me, practically, I was not confident that I was going to be able to put in really good lateral mass screws at C1 just for their anatomy. So in addition to needing the extra fixation for the distraction, that's part of the reason why I liked to go to the occiput.
okay. Did you use pre-op traction or just went straight to the OR and did it?
So if she had more weakness, I would have considered it, but no, we just went to the OR and then distracted her intra-op. So that's what we did. I think the next slide, Nader, has the CTs for comparison.
That's nice. So you use the hinge rod. You can see that's retromandibular speed. That looks okay.
Yeah, I spent about like legitimately 30 minutes under the table trying to get her head position correct. It was not a super pleasant experience, but I was very paranoid about trying to get it so that she's neutral. She actually looks okay in bed. I know she looks a little extended in that picture, but she looks okay in bed.
Good. Nice result. So yeah, this pannus should shrink. It looks more distracted, so you can see the clavicle canal angle is a little more obtuse than acute here on the left side, which is good. Good result.
Yeah, she thinks her dysphagia is better. So
yeah, good. Interesting. Good to see the follow-up. I think it's CPPD or rheumatoid pannus, but who knows? Sometimes and you can see that's why it's cranial settling, because you can see the atlantodental index is elevated, so it's a C1 C2 joint issue, but you got it nicely reduced. Really, like
somebody asked what bed we used. So we did it on the open Jackson, and then we have this head holder that it has like a handlebar basically that you can manipulate the head, and on it the head can slide rostral caudal. And so after we were okay with the position in terms of her alignment, we unlocked the sliding mechanism basically, and then slid her head rostrally or towards her vertex, I guess, in order to get that distraction. If I didn't have that, I think doing it the open Jackson with Mayfield may be challenging, and I would consider like AMSCO bed with a Mayfield, because I think that's easier to manipulate in my hands at least. But we have that head holder, so that helps. And no, I did not biopsy it.
Okay, good. Third case.
So this one is just like kind of a fun one that I thought, because since Nader said that I'm a peripheral nerve surgeon, I wanted to include some peripheral nerve type things. And this was a weird case, and I think it's just kind of interesting. So this young lady was 19 and came to our ER like 3 weeks after initiating chemotherapy for Wilms tumor that was resected. And they called me because she had this new weakness, mainly in her foot, but no pain, which is unusual because radiculopathies, when they cause weakness, typically have pain, right? And so when I hear somebody has painless weakness, I kind of think about if it's a peripheral nerve issue or not. So the next slide was supposed to be a video of an MRI of the lumbar spine. I'll just tell you, it was a super normal MRI of the lumbar spine. It was normal, right? 19-year-old girl, no other medical history. It was like a normal MRI. And I always told the residents the story when I was a resident that we saw a patient who came in with a foot drop and was going to get a TLIF. And then their other foot got weak. And they're like, maybe we don't need to do a TLIF. And they got an MRI of the brain, and it was like a huge parasagittal meningioma. And so there's a history of cancer. So I told the resident, just get an MRI of the brain just to make sure we're not missing anything. And then, she can probably go back to her index hospital for completion of her chemotherapeutic care. And it turns out she had a MET intermotor cortex that was causing her foot weakness.
Wow. So anytime someone has painless weakness, you got to investigate other etiology other than spinal etiology, like painless weakness, painless foot drop. Got to think of a peroneal nerve entrapment or peroneal neuropathy if it's an entrapment, or just spontaneous parasagittal meningiomas for like. So always painless weakness is a red flag. You don't want to like jump at the spinal operation, or you see an incidental finding in the spine unrelated to the weakness and operate on it. So painless weakness, always think about it and delve deep into working up the patient and localize the lesion appropriately. Be liberal with preoperative testing and imaging, so that you get the right diagnosis and the right treatment.
So if you want to go down, Nader, so the next one, so the next one is should be the brain, I think. Oh, so things that can cause foot weakness, obviously lumbar radic, peroneal neuropathy, as mentioned. I've seen one cervical myelopathy case present with foot weakness, or an intracranial pathology. An EMG/NCV may be helpful. So this is something I'm very big, I harp on this a lot. When we order an EMG, that's shorthand, but there are two sides to this coin. There's the EMG and then the nerve conduction studies. And so you need to order both, and you need to look at both, because when the neurologist or physiatrist, whoever does it, that's how they make the determination of a radic versus some other kind of pathology. I always recommend that you at least look at the EMG to make sure that it makes sense. As an example, let's say you're looking at somebody and you want to know if it's a C8 radic or a carpal tunnel, but they don't test any of the intrinsic hand muscles. And then it's difficult to say one way or another, right? So you just need to have like overall picture of whether or not they've done enough studies to answer your clinical question. I'm not asking anybody here to be electromyographer, obviously, but you just have to make sure that what they're saying actually makes sense, because depending on who does it, I don't always trust who does it, so I don't always trust their report. If you go to the next slide, Nader, I think, I can't remember. So this is an EMG. This is not her EMG, because again, you need to wait about 6 weeks for there to be nerve damage, so it changes. So for her, it would have been a false negative, if anything. So if you see somebody that you suspect peripheral neuropathy, but it's only been 2 weeks, you have to wait another month or so before you get an EMG, because that's when the Wallerian degeneration takes place. So you have the positive change in the muscles and all that other stuff. So I just want to draw your attention to the EMG table. So from the part that says MUAPS over to the right, you can basically just ignore that. That's all neurology stuff. Just don't even look at it. The things that I look at first are the EMG table, and I look at insertional activity, positives, sharp waves, and fibs, because that basically demonstrates if there's muscle damage. And it's really easy, because if it's normal, it just says N or none or zeros. And then if it's not normal, it says abnormal or positive, or it gives you a bunch of numbers. So it's really easy to kind of look at a tabulation, in my opinion. What you want to see for something like a peroneal neuropathy is the muscles that the peroneal nerve supply, are they affected? So that'd be like tibialis anterior, peroneus longus. And are the muscles that L5 or L4 supply, are those normal? So that'd be like gastroc or vastus, basically. So if the tib ant, which is the important one, and is positive, and the vastus is negative, that's more consistent with a peroneal neuropathy versus a radic, right? Because in a radic, you would expect vastus and tib ant to be affected. The other thing that's important, which is a little bit in the weeds, if you look at in the second highlight, there's the left biceps femoris. So the biceps femoris is actually a branch of the peroneal nerve, but it branches before the fibular head. So if that's normal, but the tib ant is abnormal, the compression is somewhere around the knee versus like a sciatic nerve lesion. That's a little bit kind of too much, but it's an important branch. The other thing you can look at is the sensories to see if they're normal. In general, the velocities should be about the old speed limit, so about 55 miles an hour, so about 55. And if they're all down, that's a peripheral neuropathy, just like a global process. You're not going to fix that with surgery usually. So that's the other thing I look at. And then finally, similar with the motors, if you look for a drop over side of compression, that can be helpful. So again, I don't expect anybody here to be a myographer, but it's just like an MRI. The first time we looked at an MRI, we didn't know what was going on. But you look at enough of them with enough practice of what you're supposed to be looking at and the report of people that you trust and seeing what they are, because in the report, they'll say, because of X, Y, and Z, this is more consistent with whatever. And, I've disagreed with them sometimes. And I've said, I don't think it's a ridic. I think it's more peroneal or vice versa. And they'll tell me this, that, or the other. And, I think it's just a good conversation to have. So if you're in a place that you don't regularly get EMGs that are of high enough quality for your clinical questions, I would recommend just looking at it to see, because, it's just anything. You just need a little bit of practice, and it can be quite straightforward, actually. So I don't know if anybody has any questions about EMGs specifically, but I just thought that was kind of a good point in terms of what other causes of foot drop can be.
Great, thank you. I mean, I think the peripheral nervous system is an extension of the spine. I think it just makes you a better spine surgeon if you're well versed in that domain, at least with diagnostics. So I'm trying my best to get better and better in that. Certainly, it just become a more comprehensive surgeon if you have expertise, at least in interpreting EMGs or the EMGs and NCVs that the patients bring with them. Okay, so what is this here?
That was supposed to be the MRI of the brain.
Okay. So it showed metastasis, from
and then they looked at the case and they took it out at the other hospital.
Okay.
Which one is this one? Oh, I remember this one. Okay, so this one fell, and I really wish that we had the pictures for this one, because I'd really like to get everybody's opinion. Because I'll tell you what I did. So just to make it kind of short, she had a C12 rotary subluxation. And I think if you look on the next slide, Nader. So the CTs are not going to play, unfortunately, but you can see her head is cocked to one position. How did she fall? She fell. Actually, I don't remember how she fell, but she fell and has a C12 rotary subluxation, and came into the ER with neck pain, but neurologically intact is kind of what would be expected. So I guess what would people do for that? Not seeing the films, obviously, but like in a general, what would we do?
So I was looking at the chat box. So this is a cock-robin head, right? Like it's
yep.
So anytime I see that, it's I always want to rule out like a rotatory subluxation, C1, C2, when you look at this scout image, cock-robin head. So yeah, that's what I think of. So sometimes with the sagittal, like you got to look at the sagittal, axial, and coronal CT, but I like to see a 3D reconstruction to look at the 3D anatomy. It's tough to kind of say, okay, so you got to look at it comprehensively, and sometimes you need a 3D reconstruction to understand the subluxation. But anytime you see a patient's head like this, you think of it's called the cock-robin head posture, and you think of a C1, C2 rotatory subluxation. What do you think?
That's exactly what she had, yeah.
Okay, great. All right, so it's rare in adults, unless it's post-traumatic or there's an infectious process going on,
Yeah, it didn't look like infection because the mass order clear. There's no bony destruction, and she fell, so it's likely traumatic.
So it's maybe traumatic. Okay.
Yeah, she was 75 actually, but yeah, so that was a cause. So what do you do for these, Nader? Do you fuse them?
So it depends on the degree. It depends on the degree of rotatory subluxation. Like I want to look at the images, low threshold to put them in traction, realign them, and then do a C1, C2 fusion or C1 to C3 fusion. Sometimes you really, if they're chronic rotatory subluxation, sometimes I go to the occiput just for points of fixation purposes. But I try to kind of, it's a C1, C2 issue. I try to address it that way, like realign the joint, and then do a posterior fusion, C1 to C3 fusion, for instance. I like to do, like what I would do, I'd put them in traction, realign them, lock them in a vest, get a CAT scan, make sure the alignment is perfect, and then go posteriorly. I mean, you know, there are many different ways of doing it, but that's the way I handle these.
So that was my original plan, and we had like this whole setup. We were going to get crown halo, serial distraction, you know, halo vest, CTs, and all this other stuff. And so that was my plan. And then lock her down, posterior C1-2 fusion, early, like in a couple days. So I called Paul Park, who I trained under in Michigan, just for some advice. And I said, "Hey, Paul, what do you do for this?"
Sorry, Dr. Swong, why didn't you call your friend? And
I didn't want to bother you, Dr. Donnelly, because you know I know you're busy on call. And
it's okay.
Paul was in
Mexico.
Okay. He was in Mexico.
Yeah. By the way, this is Dr. Hannah Kemeny. She's a resident, Northwestern neurosurgery resident. She's an R4. She's rotating here now at the Western region, Central DuPage Hospital. So just, you guys are curious. Yeah, keep going.
So Paul was like, "Oh, Kevin, I just turned their head." I said, "What?" He goes, "No, I just turned their head and I put them in a collar and it's fine."
You can do that if it's a subluxation is not severe. Absolutely, we do that for kids. But
no, I was like, "Paul, that sounds crazy." So no, I'll be fine, Kevin. Trust me. I was like, "Okay." So I went back to her bedside and I tried to turn her head and I felt a click and I was like, that might be enough. And we got a CT and I didn't reduce her. And so the next day I went back to her room and I turned her head some more. And have you ever seen those videos on YouTube? Those like chiropractic manipulation videos?
Yeah.
Because that's what it sounded like.
Yeah.
It was.
I mean, you can do muscle relaxants and relax them and see if they reduce in the neck color. I do that for younger people. As I mentioned, it all depends on how bad is the rotatory subluxation. If it's mild, then you can do that. Like it's just need to see how much you need for it to budge. You know, it's not like a one size fits all. If it's a mild subluxation, acute, it's the easiest to reduce. If it's chronic, it's the most difficult to reduce. So usually acute pathologies, whether it's traumatic or inflammatory or tumor, they're easy to reduce because they're so unstable.
So she reduced and I kept her in a collar, and then I'm going to follow her up without a fusion. So we'll see how she does.
Okay, fair, good. So you know, this looks. You want to look always at the arch and then that C2. You got to look at these cuts and see if the arch and C2, make sure there's no rotation. But that's good.
So this is the last case. This one I just thought I included because this is something that every spine surgeon is going to see. It's unfortunately relatively common, but fortunately doesn't need anything else in most cases. This gentleman had an ACGF in August of last year, and he basically had weakness in shoulder abduction and elbow flexion that was new post-operatively and persistent. I think I saw him like 6 months later or so.
Mm-hmm. Okay.
So if I remember correctly, the CT didn't demonstrate like a lot of residual stenosis or anything, but clinically he had a C5 stretch palsy. And so he came to me to see, you know, what we could do about it in terms of reconstruction. As previously mentioned, discussed, you know, the other thing I do is peripheral nerve things, and that includes like brachial plexus reconstructions, nerve transfers, graft repair. There is a growing but still limited body of evidence for nerve transfers for post-operative C5 stretch palsies that don't get better. And in general, the results are good. There's some discussion amongst the nerve surgeons, the best ways to treat it, if it's end-to-end or side-to-end. That's a little in the weeds. But I think most people agree that if there's a good option with low morbidity to restore function, that it's reasonable to do it. He underwent when we think about a C5 stretch palsy. There,
Dr. Swong, sorry to interrupt. I just want to introduce you to Dr. Alex Momagani, my friend. He's one of the co-hosts. Thanks for joining us, Alex. You're the best. You're like, what do you think of the plate, Alex? I mean, it's not like our plates look supreme every single time, but any comments on this plate? Is it?
Hello, Kevin. It's nice to see you. Nice having you here. It's a great cases. Well, actually, there is even a publication that said that an oblique plate
Biomechanical advantage
asymmetrically would be better strength than written in the textbooks. So the only problem I have is explaining the patients when they see the X-ray, why is this oblique? So this is the only problem. So I can live with this plate very good, and I would never revise any oblique plate in monosegmentals. When you go for more segments, you fall into trouble to place both screws in the vertebral body. But so I would just keep this plate and explain that it's okay.
Okay.
yeah, that's what the residents like to tell me whenever our plates don't look great. It's better rotary resistance.
Okay, good. So all right. So this all right, let's continue. Sorry to interrupt you.
No, of course. So when we talk about a C5 stretch, what we kind of really mean is a C5-6 or an upper trunk, because C5 is definitely deltoid, but bicep is mainly C6 with a little contribution from C5. And so my personal theory is that C5 stretch is a misnomer for an upper trunk palsy, because the way it usually presents is with supraspinatus, deltoid, and biceps weakness. In any other setting, that's an upper trunk palsy. It's just in spine, the first case report of a postoperative nerve deficit was for a C5 foraminotomy. So that, I think that nomenclature is kind of stuck around, but that's my own personal thing. Because it represents essentially an upper trunk lesion, patients will often have external rotation weakness, which is infraspinatus. So sometimes when we do a reconstruction, we have to do a supraspinatus reconstruction, a deltoid reconstruction, and a biceps reconstruction. This particular gentleman, he had preserved infraspinatus, but weakened supraspinatus function and weakened deltoid and elbow flexion. In those cases, for me personally, the rate of recovery from an infraspinatus after nerve transfer is disappointingly low. And so if I were to do a supraspinatus nerve reconstruction, suprascapular nerve reconstruction, he would lose his infraspinatus function completely. So in those situations, I tend to favor just doing a deltoid reconstruction and a biceps reconstruction, because that helps generate the most function, in my opinion. So he had a radial nerve branch to the axillary nerve transfer, and then what's called the Oberlin procedure, which is an ulnar nerve fascicle to the biceps branch of the musculocutaneous nerve. There's some evidence to suggest even at 2 years, some of the function can be good, which kind of lines up because there's other evidence to suggest that at 2 years, the maximum recovery from the C5 stretch is kind of taking place. So those two things kind of converge, meaning, if we look at this like a plexus, we generally want to intervene around 6 months. But the problem is most patients don't see a nerve specialist until about a year. But that means that it's not really too late at a year. So if you have a patient who has had persistent weakness, even after a year, it's not necessarily too late to at least consider some of these reconstructive options. Because especially for elbow flexion, we're very good at helping elbow flexion. That can be very, they can be life-changing for a patient, because then they can like feed and take care of themselves. Whereas if their elbow's weak, that's, very difficult. So that's what he had. He's only like 3 weeks out, so it's too early to tell his results. The next couple of slides are intraoperative slides so that would be the ulnar nerve fascicle dissection. And then the slide after that is a postoperative result of another patient, so showing that like patients can get better. So when I first started like getting interested in peripheral nerve and brachial plexus surgery, the kind of the running joke was You don't ever make them better. They're always still the same, but you actually can make some people better. And this is just a video. This is a younger gentleman who had a similar injury, who got better in his elbow flexion and shoulder abduction. So, but that last case is mainly just to say that C5 stretch happens to everybody. You know, earlier referral to a nerve specialist is better than late referral, but even after a year, it's not too late.
Excellent. Kevin, so going back to this slide, so his ACDF was at C5-6. You'd still see a C5 palsy with these, or?
Well, again, that's why I think part of it's a misnomer, because, you know, so there are two things. One, the plexus has a lot of variability. So if we think it's one nerve root, you know, there's cross connection. So I think that's part of it. But two, you know, it's not always just the level of where, you know, that's affected. It sometimes it just crosses myotomes.
Got it. Excellent. Any comments, Alex?
Yeah, I think the problem with C5 palsy, if you have degenerative cervical spine, the patients are at great risk of receiving additional adhesion level fusion, multiple segments fusion, and they're ending up in long constructs, anterior, posterior, and this is surgery far beyond the needs of the patients. And it's very good that we have this communication between orthopedic spine, looking at kyphosis and stability and posture and alignment, and the neurosurgical philosophy of function, plexus reconstruction is very nice. And I think the C5 palsy is always very astonishing if it happens the first time in your career when you're a young attending, to keep calm and not to run into revision surgery at the spine. It's very good to get these reminders every month, every half a year, because it's so important that we don't rush into a wrong decision. Because when you look at the spine, there's all my thoughts, my orthopedic thoughts of stylotrosis. Dr. Birchuk mentioned maybe the screws are too short, it's not healed. And so this is so important to get this awareness about function and function restoration. This could be completely different goal that helps the patient than revision surgery at the spine. Thank you very much for showing this.
Oh, my pleasure. I've actually seen, you know, another patient had like a posterior surgery, had a C5 stretch, then he had an anterior revision, and you know, the problem isn't foraminal compression at that point, right? Like the problem we think is either traction on the nerve or revascularization or oxidative injury of the spinal cord, right? We don't actually really know the cause, which is part of the problem, but I think you're correct. You know, when you're residents or when you're trainees, especially, you know, you're taught to make what's it called? A mistake in motion, right? Like doing more is always better than like kind of sitting and watching the natural history. And I think, especially as a young attending, that's a hard lesson to not do consistently, right? Like it's better to make a mistake in motion versus not doing something, even though that may be the natural history. So, you know, I think that is difficult for a surgical subspecialist to kind of go through.
Excellent. Thanks for sharing your cases, Kevin, with us. That's great. You know, it's a variety of cases from trauma to peripheral nerve to, you know, the thought process about how to reduce, you know, cranial settling. That's great, because any spine surgeon will face that on call or in clinic. And I can't thank you enough for joining us this evening. Now, who is presenting next week, Alex? Do you know?
I don't know. I will look. Kevin, may I ask you a last question from the chat box?
Yeah. Of course.
Dr. Al-Gaddafi asks, I think he's from Libya, what is your management in this case of the cervical and metasthetic case? Do you use rigid neck collar or do you use soft collars? What is your external orthosis philosophy?
Oh, so I guess it kind of just depends. So let's say that it's a cervical med that causes compression, no cord compression, but it's just like kind of a functional thing. They have neck pain. I would probably recommend a rigid orthosis for that. I guess in most situations, I would base it on the patient's complaints. So if they didn't have any neck pain and they're neurologically intact, then I would probably say call for comfort. If they're having neck pain and the compression was bad and their life expectancy was acceptable, I think surgery would be a reasonable indication. And in that situation, I would probably recommend a rigid orthosis, external orthosis also. I have personally a very high bar for something like a crown halo traction in terms of like immobilization. But let's say it's like lymphoma, I would probably do rigid orthosis, radiation, and then see how it reconstructs and then kind of go from there. So it's a good question. It's a little difficult to kind of pigeonhole my answer, just, because there's just a lot, it just depends. There's a lot of variables that would factor into the decision.
You have one management, one standard operation procedure in Northwestern, or is every surgeon doing its own? May I ask, is this, do you have an agreement and like a consensus in Northwestern?
So we have an indications conference, and I think most people do similar things. I think the way that we differ, particularly like ortho versus neuro, would be some of kind of like what you alluded to earlier, structural considerations versus like function considerations, right? I think, if you look at like indirect decompression as an example, my experience has been orthopedic surgeons tend to be more comfortable with that as a concept versus like neurosurgeons. I mean, obviously there's a lot of interplay now, but in my fairly limited experience, that's been one of the bigger differences in terms of ortho versus neuro. But I think we align pretty well on what we do. I think there are different techniques for how we do it, but I think the surgical goals are pretty in line.
Thank you. Now, I found out next week, Dr. Coitan is hosting from Brazil, Dr. Bruno Sacilotto, and he's talking about why he converted from tubular to endoscopic spine surgery.
Oh, that's a great presentation. That's great. I'm gonna tune into that. That's great. Awesome. So I can't thank you enough for joining us tonight. Thank you again, Dr. Swong, for your great and thoughtful presentation and interactive session. And thanks, Alex, for co-hosting as usual. You're truly the best. And stay tuned, everybody, for next week. We'll put out the flyer early next week or this weekend about our next participant. And have a good night, everybody. See you, Kevin.
Bye.
Bye.